From the JAMA Network, this is JAMA Dermatology Author Interviews. Conversations with authors exploring the latest clinical research,
Work
reviews,
RVUs
and
were higher in
opinions
encounters
featured
with
in
older,
JAMA
white male
Dermatology.
patients.
Hello, and welcome to our listeners around the world. You're listening to
Persons
JAMA
of racial
Dermatology
and
Author
ethnic
Interviews.
minority groups.
Thanks for joining us. I'm Dr. Adamson, the web editor for JAMA Dermatology and the host of this podcast episode. Work Relative Value Units, also known as Work RVUs, are assigned by the Centers for Medicare and Medicaid Services as an estimate of physician time and effort for rendering medical services. Work RVUs are linked to payment for medical services and are used by many private and public health systems to calculate physician productivity and compensation. In a new study in JAMA Dermatology, authors aim to determine the association of patient race, age, and sex with work RVUs generated by outpatient dermatology encounters after 2021, the year Medicare made changes to the fee schedule. Dr. Lauren Orenstein is an assistant professor in the Department of Dermatology at Emory University School of Medicine in Atlanta, Georgia. She is the corresponding author of this new study and here to discuss this work and its findings and put it into context. Welcome to the podcast, Dr. Orenstein.
Thanks so much for having me, Dr. Adamson. Happy to be here.
I'm glad we finally got you on the podcast. I've been watching your work over the years, whether it's in hidradenitis suppurativa or looking at some health services questions. And this study in particular, it intrigued me. So thank you for your willingness to come on the podcast.
I'm flattered and I'm a big fan of yours as well.
All right. So I know you work at Emory, but some of the listeners may not know this. What is your role at Emory? What is your subspecialty within dermatology, and how much clinic do you do versus research?
Thanks so much for asking. I primarily practice at Grady Memorial Hospital, which is the public hospital in Atlanta. And at Grady, I am 25% clinical. I spend my clinical time in a complex medical dermatology clinic with the residents, and then also spend time in a hidradenitis specialty clinic, which we recently started at Grady. My research work, the other 75%, focuses on clinical research within hidradenitis suppurativa, particularly focused on pain in HS, as well as health services research kind of across the dermatology spectrum.
And so you study health services research, so you have an interest in how we deliver care, the value that we deliver to our patients. Is this kind of how you got interested in this subject? I know that you had a previous study published in JAMA Dermatology looking at work RVUs and their relationship to race and sex. Why did you feel compelled to do this specific study? And maybe, give the listeners some context about your previous study.
Yeah, absolutely. Some of the drive for this study may actually be selfish. I, over the years, looked at my own productivity measures and I kept wondering, I feel like I'm working really hard in clinic, but these numbers are maybe suggesting something else. So our prior work was a single center retrospective study where we looked at clinical productivity as measured by work RVUs and outpatient dermatology visits. And we found in that study that outpatient encounters for patients who are female, who are persons of
racial and ethnic minority groups,
and younger generated on average fewer work RVUs compared to dermatology visits for older white male patients. So in 2021, there were these important updates to the Medicare physician fee schedule, which were intended to place more emphasis on medical decision making. And so we were curious as a team to see whether these changes had made any difference in the previously observed productivity differences by patient age, race, and sex.
And if you can provide clarification, in your previous study, what you found is a lot of that difference was generated by procedures, right?
Correct, yes. So we saw when we looked at only the kind of medical dermatology encounters that a large proportion of those differences were generated by biopsies and destructions of premalignant lesions. And then when we included the surgical practices, we saw an even bigger contribution of procedures in those differences in RVUs between different patient groups.
Okay, so then the motivation for this study was to see whether those updates by Medicare actually could do anything to reduce that difference. Because I guess part of the motivation for those updates was to help with work RVUs being recognized for cognitive work as they have been more generous with procedural work.
Yeah, that's precisely right. We kind of hypothesized that in certain patient demographics, just because of the epidemiology of different skin diseases, we thought that, well, inflammatory skin diseases often take more cognitive effort to provide care for these patients, and these inflammatory skin diseases disproportionately affect younger female patients' skin of color compared to skin cancers, which often are treated with procedures. And so we were interested to see whether these policy changes, and particularly the emphasis on cognitive work, would help close some of the gap that we had observed previously.
And for this specific study, you actually expanded the outpatient clinics that you were looking at. You mind telling the audience how that differed from your previous study?
Yes. So previously we had included only one outpatient dermatology practice. But for this study, we wanted to make sure that this wasn't an effect that was particular to just one institution. And so we were fortunate to have partners from a total of 3 academic dermatology departments. And we looked at a total of over 89,000 outpatient dermatology encounters among adult patients.
And the other two sites were at Duke and then Brigham and Women's Hospital in Boston, if I'm not mistaken.
That's right. And we at Emory partnered with Brigham and Duke to collect data across 3 sites.
So this study was much larger than your previous one. What did you find? What were some of the main results looking at productivity related to clinic visits across race, sex, as well as any other demographics?
There were a few main findings. First of all, we saw an increase in work RVUs per encounter across the board. So, compared to before the 2021 fee schedule update, where the average work RVUs that were charged for outpatient dermatology encounters was 1.44, that increased to 1.8 after the update. So, on average, everybody's work RVU productivity increased with these changes. After the 2021 update, we saw a persistent but lessened gap in the work RVU generation for outpatient dermatology encounters by race. So after the update, for example, encounters for Black patients still generated 0.14 RVUs fewer than encounters for white patients after adjusting for age and sex. But this 0.14 work RVU difference was smaller compared to what we had seen before the 2021 update, when there was a gap of 0.22 work RVUs fewer generated per patient encounter for Black patients compared to white patients. Similarly, encounters for Asian patients had generated 0.24 work RVUs fewer than for white patients before the update. But after the update, those encounters for Asian patients only generated 0.12 work RVUs fewer. So the first point was that across the board, there were more work RVUs per encounter. After the update, there was still a gap by patient race, but that gap had lessened. And third, the differences in work RVU generation across patient age and sex were pretty much unchanged. Those persisted after the 2021 update.
So are these results surprising to you? Did you think that this difference was only going to be reflected across race and not necessarily across sex?
Yeah, I was surprised to see that the gap only closed across race and not across sex. And truthfully, that's something I'm still puzzling over a little bit, is why the difference here. Some of it could be explained by difference in epidemiology of dermatologic diseases, but I'm not sure that that totally explains it in my mind.
And you said there was no difference by age before and after the 2021 fee schedule update.
Correct. Encounters for older patients on average generate a little bit more. It's statistically significant. How clinically relevant it is, I'm not sure, but encounters for older patients generate a small amount of RVUs more compared to younger patients, and that just remained unchanged from before and after.
And was the types of differences across these demographics still the same? Put another way, was it procedure that was dictating the difference across race?
Yeah, absolutely. So in the first study, we found that premalignant destruction and biopsy accounted for the majority of differences by patient age, race, and sex, but only a fraction. Whereas in this subsequent study, premalignant destructions and biopsies accounted really for all of the differences in work RVUs by patient age, race, and sex. So a much larger proportion.
Did you hypothesize that that was going to be the case beforehand? Or did that also kind of surprise you a bit?
I mean, I think that we had assumed or hypothesized that these procedural codes would account for a large fraction, but I'm not sure that I expected to see, even in some cases, a reversal of the trend when we accounted for these procedures. Meaning that once we took these procedures out of the mix, actually encounters for Black patients on average generated more work RVUs than encounters for white patients.
So, what you're saying is that it's a lot more complex when you look under the hood than it does look like on the surface, explaining these differences.
Absolutely. Absolutely.
And so, what should listeners take away from your study? Are these structural problems in the way that we reward physicians around work the issue? Or is this merely epidemiology that's, driving the difference?
Thanks for the question. I think the biggest take home for me was just the idea that policy, and particularly the work RVU assignments at the level of the RUC, can be an important lever for influencing incentives to care and cater to specific patient populations. Now, I think it's really important that we also acknowledge that this study design cannot help determine whether the remaining work RVU differences that we see across patient demographics are equitable. Ultimately, as a specialty, we should want to see RVU assignments that fairly assess provider effort and give appropriate weight to all skin diseases, whether we're talking about inflammatory skin diseases that predominantly have more medical decision making versus skin cancers, where there are more procedures. Really, we just want to make sure that all of this is appropriately balanced. I think that we've seen with this study, it's just one piece of the puzzle, but it shows that there is the potential for these differences in work RVUs to systematically disincentivize care for some patient populations, and particularly those who are least likely to experience skin cancers. So it's important for our specialty and for the RUC to get this right, to examine the system and ensure that we have the right balance in work RVU assignments across medical decision making and in office procedures.
Yeah, for the listeners that don't know what the RUC is, it's the Relative Value Scale Update Committee, which is responsible for making recommendations to the Centers for Medicare and Medicaid Services, or CMS, that influence how physicians are paid. And, I agree with you that this study is just one piece of the puzzle, and it doesn't really tell us about intent or whether dermatologists are prioritizing some patients over the other. We just don't know that. And, recognizing that skin cancer and premalignant lesions are important. But I also agree with you that inflammatory diseases and the work that we do in HS, atopic dermatitis, et cetera, the list goes on and on and on, are also important. And that we need to get this right for everyone. I think we're all on the same page about that. So, Lauren, Where do you go from here with this study? Are there any follow-ups that you want to pursue? Perhaps maybe there's some kind of policy making changes that you may be for. What do you think?
Well, without giving too much away, I think there are some future steps kind of in the works. We had some initial studies also that showed gaps in work review productivity in adult versus pediatric dermatology encounters. So I'm interested in looking at that. But ultimately, I think what we're going to need are some time motion studies that kind of tell us more about whether these work RVU differences accurately reflect physician effort. And once we as a specialty have kind of come to terms or agreement on how these work RVU assignments should be done to accurately reflect effort, I think potentially policy changes will be needed to ensure equitable dermatologic care.
Dr. Orenstein, I want to thank you for being on the podcast.
Thank you so much for having me, Dr. Adamson. It's really a pleasure.
I'm Dr. Adewole Adamson, and I've been speaking with Dr. Lauren Orenstein about differences in productivity measures among outpatient dermatology encounters by patient race, sex, and age. You can find a link to the paper in this episode's description. This episode was produced by Daniel Musisi at the JAMA Network. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com or search for JAMA Network wherever you get your podcasts. Thanks for listening. Catch you on the next episode of the JAMA Dermatology Podcast.
This content is protected by copyright by the American Medical Association with all rights reserved, including those for text and data mining, AI training, and similar technologies.